An analysis of the Affordable Care Act, impacts on access, cost, and quality. The overarching goal of the Affordable Care Act of 2010 is to substantially reduce the number of uninsured Americans. There are a number of gradually implemented new policies that include health insurance exchanges, subsidies for coverage, and individual mandate and health insurance market reform. This will lead to an increase in healthcare access. Under the Affordable Care Act, a large proportion of uninsured populations will gain coverage, but this coverage will result in an increase in healthcare expenditures. Undoubtedly, providers will encounter newly eligible clients, a notable shift in payers, and changing financial schemes to expand coverage. What is the likely impact of the Affordable Care Act on healthcare access, cost, and quality? The political debate over the Affordable Care Act's impact on cost, quality, and accessibility. The discussion debate around the Affordable Care Act and how to provide access to health care through insurance coverage is not new. Beginning with Germany, compulsory sickness insurance had decimated throughout the European continent by 1912. Motivated by industrial accidents, it was believed that the trend of sick insurance would continue to the U.S. The American Association of Labor Legislation was founded in 1906 and advocated for government health systems. The American Association of Labor Legislation argued that national health care could benefit both social and economic concerns. It was proposed that national health insurance could ease the poverty and sickness due to the individuals losing everything due to the high cost of medical care. Supporters also proposed that a national health insurance would contribute to the overall economic efficiency of the nation by reducing illness and lengthening life. In 1917, a standard health care bill was proposed in 15 states, only to be opposed. Arguments of political inexpediency, institutional dissimilarities, ideological differences, and tax aversion are several reasons why repeated attempts to pass national health insurance legislation had failed. Public and political support for the Affordable Care Act. Political affiliation continues to be the greatest predictor of support for the Affordable Care Act. While alternate factors such as race and ideology do play a role, factors such as income and status of employment do not represent significant factors in predicting support. The Affordable Care Act remains very politically divisive. From the time of its passing, it has continued to be a contentious debate. Even as it becomes established into law from the Supreme Court decisions, the question of whether the Affordable Care Act will eventually be accepted rather than a source of ongoing decades-long political war is yet to be seen. Current political developments. The legal challenges to cost-sharing subsidies for individuals and families buying insurance plans in 34 states was decided on June 25, 2015, in the case of King v. Burwell. The U.S. Supreme Court ruled to uphold the legality of these subsidies in states the federal government operates insurance marketplaces because the state has not established them. Who is newly covered? The Affordable Care Act provides additional coverage to those who were previously uninsurable or chose not to be insured. Prior to 2010, Americans with pre-existing conditions paid higher premiums or are not eligible for coverage. With the Affordable Care Act in 2010, new provisions were made for those who were uninsured for at least 6 months. Young adults under the age of 26 could also remain under their parents' insurance coverage. This benefit makes healthcare affordable. Being married, not living with, or financially independent from your parents, attending school, or currently eligible for your employer's plan does not deem you ineligible for this benefit. If you retire before you were eligible for Medicare, the Affordable Care Act subsidizes employment-based plans for individuals between 55 and 65. However, as of 2014, more affordable coverage has been provided by the exchanges offered. Lastly, states received federal matching funds to cover additional low-income individuals and families who previously were not covered by Medicaid. In 2011, The Community First Choice option allowed states to offer home and community-based services through Medicaid. This took the place of institutional care in nursing homes. In 2012, voluntary long-term care insurance options were proposed. This provided cash benefits to adults who became disabled. However, this was not implemented due to its deep flaws and eventually was dismissed because it was unworkable. Flaws included benefit to premium ratio paid out more than would be put in overall and no underwriting prior to coverage. In 2013, open enrollment began in the health insurance market. The open enrollment period allowed for individuals and small businesses to purchase insurance plans. These healthcare exchanges would allow for comparison of plans. Individuals and small businesses could now shop around for affordable plans. In 2014, there was an increase in Medicaid coverage. This increased access to Medicaid to individuals who earned less than 133% of the poverty level. The poverty level equated to approximately $14,000 for an individual and $29,000 for a family of four. Applying for coverage can be categorized as open enrollment and closed enrollment. Health insurance can be enrolled through employer-provided coverage, purchased privately, or through the government-sponsored health exchange during open enrollment periods. If the open enrollment period is closed for the health exchanges, you can still attempt to gain coverage. One way is to qualify for a special enrollment period. To qualify, you must have gone through an acceptable categorized life change. Examples of a life change include having a baby, marriage, loss of existing coverage, adopting a child, placing a child for adoption or foster care, moving to a new residence, becoming a citizen, and being set free from incarceration. If you already have Medicaid coverage, reasons that are considered for special enrollment include an income or household change that affects premium tax credit or cost sharing reductions. If you qualify for Medicaid and CHIP, which is Children's Health Insurance Programs, you can apply anytime. With the Affordable Care Act, states who participate in expanding their Medicaid coverage makes additional provisions if you are under the age of 65 and have an income up to 133% of the poverty level. CHIP is an alternate to Medicaid for children whose families make too much to qualify for Medicaid coverage. In some states, CHIP provides coverage for pregnant women and sometimes parents. Routine checkups, immunizations, visits to the doctor, prescriptions, vision and dental care, hospital care, labs, x-rays, and emergency services are covered under CHIP. Applying for coverage using health exchanges can be done via a few ways. There are 4 ways to apply. Online, through healthcare.gov, the phone, in person, or by mail. To get coverage online, visit healthcare.gov and go to the Get Coverage page. By selecting your state and filling out the questionnaire, the enrollee will be able to see which exchanges are available to them and decide which is the most suitable for themselves. By phone, the enrollee can call 1-800-318-2596. This line is open 24 hours per day, 7 days a week. This line will inform the enrollee whether your state has health exchanges available and provide also the direct number to your state's marketplace. The representative will help the enrollee fill out the application and review it to see if the enrollee is eligible for coverage. Upon review, a plan selection can be made. In person, consumer assistant organizations, authorized insurance brokers, local health departments, or departments of social services are available for assistance. You can visit www.localhelp.healthcare.gov to find the appropriate personnel who can assist the enrollee to fill out an online or paper application. By mail, an application can be requested or searched online. By filling out the application and mailing it in, eligibility can be determined. If the enrollee is eligible, an account can be created online, or the enrollee can contact the Marketplace call center at 1-800-318-2596. Both state and federal policymakers have been faced with significant implementation challenges with new provisions under the Affordable Care Act. Three of the most noticeable implementation challenges can be attributed to state voluntary expansions of Medicaid coverage, the reform of reimbursement systems in the healthcare sector, and the establishment of health insurance marketplace. The election to expand Medicare coverage under the Affordable Care Act is up to the discretion of the state. Presently, it is unsure how many states will elect to expand Medicaid coverage, and it is clear that there is a significant variation in the composition of those opting to enroll in the program, both across and within states. If every state was to elect to expand Medicaid, however, the number of uninsured in the U.S. is expected to decrease by 23.1 million. Declining the rate of uninsured by 47.1% nationally. And the number of those enrolled in the program is expected to increase by around 18.1 million. It has been predicted that states with a high proportion of citizens with incomes below 138% of the federal poverty level will experience higher enrollment rates. In fact, multivariate analysis indicate that some states, such as Montana and Nevada, will experience a much higher enrollment rate than others. Even so, reports as recent as June 2015 indicate that the 21 states who have opted out of the expansion thus far have chosen to do so because they question the government's long-term commitment to paying for most of these costs. Both state and federal policymakers must not only navigate through expected changes that accompany an increase in healthcare coverage, but account for the composition of those who will now be insured, as a new coverage of non-elderly adults, an estimated 78% of new enrollees, will shift the landscape in which we deliver care. Since the healthcare needs of newly uninsured non-elderly adults differ from the needs of elderly adults, new challenges will emerge with the demand for healthcare services characteristic of specific demographics. These challenges will most likely require both federal and state policymakers to devise solutions to these new unanticipated repercussions from expanded coverage. In addition, both federal and state policymakers must ensure that there are ample and accessible Medicaid provider networks in place that can effectively and efficiently meet the needs of the newly insured. Prior research has indicated that access and use of care is heavily affected by language barriers. As Medicaid provider networks are designed, formed, and placed by state policymakers, special attention must be given to the geographical concentration of certain language groups. Federal policymakers must decide to increase or decrease financing for these federally qualified health centers that are tailored toward the limitations of the targeted population and geographic region. Finally, although the Affordable Care Act includes provisions that aim to increase access, reduce costs, and improve quality within Medicaid through incentives such as increases in primary care reimbursement rates, state policymakers will be faced with forming new laws to better meet the healthcare needs of both existing and new Medicare enrollees. These laws will vary from region to region and will be influenced by state differences between current coverage patterns and various socio-demographic economic factors. In attempts to lower costs and improve quality, a new provision became effective in January 2015 that linked quality of care to physician payment. Pay for performance. Essentially, physicians who provide higher quality of care will receive higher payments than those who provide lower quality of care. With the new pay for performance approach, health insurance compensates physicians according to performance evaluations, Oftentimes, these performance evaluations are based on the wide range of data, which most commonly include measures for quality of care, cost of care, and satisfaction with care, such as administrative, claims, or patient satisfaction data. Based on this data, physicians are rated by the payer according to the payer's own criteria. Many physicians have voiced concerns with the approach, mainly with concerns that additional compensation may diminish or withhold base compensations, and that the interpretation of measuring quality may produce inaccurate rating, which ultimately can harm the relationship between the patient and their physician. With arguments and skepticism surrounding performance and data measures, federal policymakers may need to consider creation of a set of criteria, regardless of payer preferences, to measure performance and quality of care. States, especially those who elect to expand Medicaid coverage, will face similar challenges as the reform of reimbursement systems continues to forward. Effective January 1, 2013, states were required to reimburse physicians providing primary care no less than 100% of Medicare payment rates and to increase federal funding to support these reimbursements. These increased rates, with aims to increase support for physicians providing primary care for Medicaid beneficiaries, plan to improve access and quality of care for the most basic primary care services. Since federal funding for the primary care increase ended as recently as December 2014, states are still adjusting to changes related to implementation. As such, there is difficulty in linking changes in provider enrollment and access to the enhanced payments. Since these rates are provided to Medicare beneficiaries only, states who have elected to abstain from expanding Medicaid are at a disadvantage. Policymakers in states with Medicaid must decide to continue or discontinue the primary care rate increase and consider the repercussions of either decision. In turn, federal policymakers must be prepared to react to the potential effects on quality of and access to care for states who decide to decline the expansion of Medicaid. Both federal and state policymakers face continuous challenges with the health insurance marketplace, most particularly those related to lack of enrollment, depletion of enrollment, and advertising funds. Over 18 million Americans have been given the opportunity to purchase health insurance in federal and state marketplaces, yet have opted not to do so. The most difficulty with enrollment can be seen with Hispanics and young adults, and resistance is seen by those who are opposed to being told that they must buy health insurance. In addition to poor utilization, the federal funds used by states to advertise enrolled citizens in various health insurance is depleting rapidly, a clear indication that we have not quite mastered a self-sustaining model for the health insurance marketplace. Some states, like Texas and Vermont, are already scrambling to secure additional funds. Regardless, if additional funds are secured, the penalty for opting out of some form of coverage will not only be implemented, but rises next year to $695 per adult. Both state and federal policymakers will need to determine how to handle those who have opted out in addition to the penalty. Since the creation of the health insurance marketplace, the federal government has been protecting insurers from unexpectedly high medical bills, a safety net for consumers that will disappear next year. In addition, insurers who are now familiar with the healthcare utilization trends of their new consumers will determine if premiums are at an optimal level to cover medical expenses. This gives the insurer full power to increase premiums for those who incur excess medical costs. Although access to basic health care has been addressed through the creation of health insurance marketplace, affordability has not been achieved. Citizens who have purchased insurance from the marketplace remain at risk for substantial out-of-pocket costs for medical care, with a maximum financial obligation of $6,850 per individual and $13,700 per family set for next year. Furthermore, there is no ceiling on costs for individuals who choose to utilize care outside of their insurance network. The Affordable Care Act and Medicaid. The 2010 Affordable Care Act expands Medicaid to all Americans under age 65 whose family income is at or below 133% of federal poverty guidelines by January 1, 2014. This equals $14,484 for an individual and $29,726 for a family of four in 2011. Medicaid will also be available for those up to age 26 after leaving foster care. Additional funding is provided to Medicaid programs to cover adults through two separate pieces: Healthcare and Education Reconciliation Act and Patient Protection and Affordable Care Act to expand Medicare coverage. Insurance coverage for everyone. Individuals cannot be dropped from insurance for any reasons as long as they are paying their premiums. Medicaid is offered to low-income families with either an enrollment fee, a limited premium, or no premium. If one does not obtain health insurance throughout the year, a shared responsibility fee will have to be paid every month. The price of one's health insurance can be based on several criteria, but gender and health status is not one of them. The demand for primary care will still steady increase from the Affordable Care Act. Health insurance premiums, will they be affected? The higher the premium of a plan, the more the plan offers. The patient will have a lower deductible, co-pays, lower out-of-pocket costs, and maximum and also better co-insurance. Deductibles and limits are based off of a policy period. Different ways to lower premiums include employer contributions, employer pays half of the premium, Medicaid, and advanced premium tax credits based off of gross income. You save more when you make less. Going the cheaper route may not always be the best plan. Premiums tend to rise based off of the economy. Inflation causes premiums to rise. This visual is showing how the Medicaid expansion will affect uninsured and low-income people through the Affordable Care Act and also states that do not support it. Is the Affordable Care Act a good or bad law? Some positive attributes include it mandates all insurance policies to cover all 10 essential health benefits. It covers people with pre-existing conditions. It includes children up to 26 years of age on parents' health insurance plans. It expands Medicaid to 138% of the federal poverty level, more coverage for childless adults. It eliminates lifetime and annual limits on coverage. It provides tax credits for the middle class, below 400% of the poverty level or $94,000 for a family of four. The main purpose of the Affordable Care Act is to lower out-of-control healthcare spending. By 2009, the year before the Affordable Care Act was passed, Medicare and Medicaid costs $676 billion. Healthcare costs rose because the uninsured mainly resorted to getting treatment in emergency care centers. The Affordable Care Act will lower healthcare costs by preventing diseases before they need emergency room treatment. The number of emergency room visits increased from 115 million in 2005 to 136 million in 2011. 1 in every 5 adults went to the emergency room. Some negative attributes of the Affordable Care Act. It will cancel insurance plans not meeting 10 essential health benefits. There is a loss of company-sponsored health insurance plans. It increases in healthcare costs due to increased preventive care and additional tests. Higher income families pay an additional 0.9% Medicare hospital tax on income above the threshold and an extra 3.8% on the lesser of investment income, like dividends and capital gains or adjusted gross income above the threshold. About 30 million people are expected to remain uninsured even after several years. Justification of the Affordable Care Act. There are balanced arguments on both sides. It is potentially a good law. It increases access to more than 3 million previously uninsured young people. It helps individuals pay premiums with federal subsidies. It focuses on preventive care with no copays. It decreases healthcare costs since chronic diseases can be prevented at an early stage. About 7.3 million people previously did not cover due to costly medical conditions remain enrolled in private coverage through the law's online marketplaces. Warnings that the law would cause premiums for most people to rise sharply have proved unfounded. The law has spurred competition, with new companies entering the market. Median increases of 4% is to be expected. 85% of those who signed up during the enrollment period qualified for federal subsidies to assist in premium payment. This is, to an extent, addresses the concern that people might lose their insurance due to high premiums. The Department of Health and Human Services estimates that hospitals will save $5.7 billion in uncompensated care costs this year because more people have insurance. The Affordable Care Act Hospital Readmission Reduction Program reduces Medicare program payments to hospitals with relatively high rates of potentially preventable readmission to encourage them to focus on patient safety and care quality. As a result of accountable care organizations, Medicare's readmission rates have reduced from 90% in the past decade to 17.8%. This translates to over 70,000 fewer preventable hospital readmissions. Accountable care organizations provides incentives for doctors and other providers to work together to provide more coordinated care to their patients. Over 250 organizations are participating in Medicare accountable care organizations, giving more than 4 million Medicare beneficiaries access to high-quality coordinated care throughout the nation as a result of increased quality delivery of healthcare services. Accountable care organizations are estimated to save the Medicare program up to $940 million in the first 4 years. The Affordable Care Act addresses critical concerns in the U.S. health industry. Good attributes of the law should be consolidated, and it focuses on improving coverage for over 30 million citizens.